Tēnā koutou katoa, and welcome to this evening's webinar. Our thoughts are with those who've been affected by the recent flooding, and hopefully we will not see too much more rain in the coming weeks. This evening we are joined by the lovely Sharyn. Sharyn works for older people's mental health within the community as an occupational therapist at Canterbury DHB and as a dementia educator for Walking in Another Shoes programme, which is a South Island education initiative aimed at assisting the dementia care workforce to move towards a more person-centred practice. Her areas of interest include dementia, maintaining and enhancing function, and empowering others through education. Her experience covers both inpatient and community settings. Sharyn is passionate about using a person-centred care approach, particularly to inspire aged residential care workers and to support those living with dementia and their whanau. I'm certainly interested to hear what Sharyn has to say this evening. Now we're all loaded up with our presentations.
Thanks, Kathy. That was a nice introduction. Thank you very much. Hello, everyone. I can't help but wondering if I have fellow occupational therapists in the audience. It would be nice to know. Maybe even some I trained with, or I think it's coming up 25 plus years ago. So anyway, welcome everyone. As Kathy has said, I'm here to talk about person-centred care. And I just want to start to talk about what person-centred care really means. As you know, there's many terms around at the moment that include facets of person-centred care, such as patient-centred care, personalised medical care. And most of us use these terms and we interchange them, and we all endeavour to embed them in our practice, I'm sure, when we're working with our clients or our patients. But I believe it is only after working as an occupational therapist for nearly 30 years and in the field of dementia for over 10 years now, I think that I can truly say that I believe I now really embrace person-centred care in my practice. I don't believe that personalised medical care and person-centred care are exactly the same thing. One is not better than the other, but they need to walk alongside each other. And so the person is really at the core of what we do. I do have a confession to make. I'm not a professed expert at person-centred care theory. So I'm sorry if you expected that. If you can gain this knowledge throughout the literature, just as I have done, and through reputable sites via Google. At the end, I have a website which gives you links to lots of information, and that's the New Zealand Dementia Foundation. However, what I do hope to do this evening, and I hope that's what you're here for, is to encourage you to think about what person-centred care might look like in your practice. And so before we even do that, I need to briefly review and understand person-centred theory and its origins. So what is person-centred care? Its origins are actually in psychotherapy, and with Carl Rogers' work of the 1960s. However, it wasn't actually used in relation to dementia care until Tom Kitwood, a UK psychiatrist, who I'm sure many of you have heard of. He first referenced person-centred care approaches in dementia in around 1988. And he did this by removing the emphasis of the medical and behavioural models of dementia management. And actually, believe it or not, that was quite a radical thing in its day. The heart of this approach really looks at the person and the individual first. It does recognise that, yes, firstly, a person has a diagnosis of dementia, that's important, and that does alter their thinking their mood, their movement, maybe and often their functioning in everyday life. However, this is only part of the picture. And central to the picture is who we are as individuals. We must remember dementia is actually an individual condition. If I got dementia, it would look quite different than if you got dementia. We would both respond to it quite differently. So person-centred care moves away from thinking that all people with dementia will be the same, that we'll all be homogenous. And I think sometimes as I get older, I think people think that of old people in general. And so if you think all people are the same, then we'd all be treated the same. And that's not the case. So further to this, and there's a picture of Tom Kitwood, who's since passed away. He died quite young, in his 60s. Further to this, Kitwood coined the phrase personhood. Personhood is the way we feel about ourselves, which is influenced by the world around us and how the world sees us and how we then respond to that. It is the relationships and our social environment that influence us. So if we apply this to dementia, it was quite new because the medical model believed that the things a person was doing was because of the brain damage from the dementia. So if we take a step back and think about this, I want you to just look at the following activities. Just run your eyes along that list. Which of these activities would you be unlikely to do, and why? And how would you react if you were made to do these? And what might your behaviours look like if you were made to do them? And then if we take it another step, would we act the same way if we had dementia? I think I would. So people with dementia have rights. They need to feel respected and safe. And they actually have valid reasons for this, just as we do. It's interesting to think about when we see a person with dementia who's perhaps withdrawn or angry or frustrated, or they're not functioning really very well and they're really struggling. It actually may not be because of the cognitive damage. It actually may be because their personhood has shrunk. That life is just too hard. Dawn Brooker, in 2007, she also worked with Tom Kitwood. This is out of the Bradford University in the UK. And she suggested an acronym, which I quite like to use, that is called VIPs. And it summarises the broader meaning of person-centred care. So, first of all, people with dementia and their carers must be valued. So I think it's good to ask ourselves this question and turn it on us. Do my actions show that I respect and value and honour this person? Secondly, she says that they must be treated as individuals. So am I treating this person as a unique individual? Thirdly, she suggests that the perspective of the person with dementia must inform our understanding. I particularly like this one. Am I making a serious attempt to see my actions from the perspective of the person I'm trying to help? How might my actions be interpreted? And lastly, she says that the social environment must be attended to because of the fundamental importance of relationships in sustaining personhood. So do my actions help this person feel socially supported and they are not alone? So then I'll just move on to language. In person-centred care, we're actually reminded how powerful language is. And getting it right is a particular passion of mine with my students. We actually have a swear jar, but when they use labels. And I'm guilty of it as well. I think sometimes it's our economy of language. We have shortened versions of things that actually turn into labels. I'll explain a little bit about that. So we all know that we react physically and emotionally to what is said to us and about us. The language used affects us with just as much as physical actions. And this is the power of words, and this is exactly the same for someone with dementia. If we think back, historically, language used to describe dementia has been largely negative. You will have, and I sometimes, unfortunately, still hear these words, and I'm thinking like the demented person, or she's got senile dementia. They're more rarely used now, but I still hear them. Words like this actually can pervade our perceptions and our approaches to care. So I think it's good to step back and think of our language. What they do is they focus on illness rather than wellness and hope, and victims rather than the whole person. So if we take that a step further and thinking, I want you to think a bit more about the phrase challenging behaviours. I believe this is often overused. It doesn't really tell you much about what's going on at all. And then underneath that, we have all these labels. And I'm sure you can think of many of them. And here's a few. Attention seeking, a shouter, a screamer, aggressive, non-compliant, that's a common one. They need a firm approach, difficult to deal with, sundowner, kicking off is what one of my students used recently. So the list goes on, and I'm sure, as I said, you can think of some more. So if we use person-centred language from the start, we can actually, I think we can turn the statement challenging behaviours on its head. Surely if we follow the principles of personhood, then the actual behaviours are those that challenge us. They concern us, not the other way around. They are actually behaviours of concern. And if we look at it this way, then I believe we're really putting the person at the centre, and then we can begin to unpack what is really going on for that person. I'm thinking about a question that I think would be good for you to challenge yourself. If we use labels, and we'll go on to that, back to that actually, am I really making a serious attempt to see my actions or the way I communicate from the perspective of the person I'm trying to help? How might my language be interpreted by them? So it's not just actions. I'll just move on to unpack a little bit more about behaviours of concern. A person with dementia may start to behave differently. That's when we notice something's wrong. It's a behaviour that concerns us. They may develop behaviours that are also distressing for themselves and the carers and others around them. As I said earlier, when a person with dementia behaves differently, this is often mistakenly seen as a direct result of the dementia or a symptom of the condition. The behaviour may have many causes, including the difficulties relating to dementia, such as memory loss or language, but there also may be other causes. This is when we need to act like a detective to really see the person as an individual and get inside their world. It can be really complicated and we don't always get it right. I definitely don't. The possible causes of someone behaving out of character may be broadly divided into the following: biological, which includes physical health, cognitive ability, sensory profile, and medications; psychological and emotional needs, which include their life history, personality traits, their mental health history, their emotional and psychological needs; and then social, the environment they live in, including their social interactions. It can be really useful when considering the behaviours of concern to follow a step-by-step, solution-focused approach. And this is something that can be termed brainstorming and can be useful when trying to find solutions and help you come up with ideas. I think it's really important to be curious, don't give up, and remember no idea is a silly idea. Here is an example. That's out of order, but anyway, here is an example of a brainstorming plan, which may help your detective work. I will give you just a few minutes to read through this. And I'm sure it's no different than what you know, but I think it's what you do with that in the plan. And the more detail, the better. I would actually like to explore the emotional needs in a little bit more depth, as often this can be a little bit harder to unpack. A behaviour can, when you think about it, can actually be interpreted as a way of communicating something that a person with dementia cannot understand or put into words. You could actually call it a reaction. So imagine if your brain is failing and you're aware of the changes and you're scared and you can't make sense of them and you're getting anxious, you're going to have a reaction. And that's quite normal. I'm sure we've had times when our memory's failing and something's not quite working and we can get quite stressed, like I did before this webinar. And I did all sorts of odd things. So it is quite normal. We can also ask ourselves, is this in response to an unmet emotional need? The emotional needs model is really useful as well in person-centred care work. It was expanded by Jane Verity, an occupational therapist, and she describes 6 core emotional needs that we all have. I'm just going to find a little bit out of order. That's right. And And sometimes it's good to consider these when we're trying to see what's underneath for a person with dementia. They are to love and be loved, to be needed and useful, to have the opportunity to care, to have our identity reinforced, to be able to make choices, and to be able to express emotions freely. I'm just going to share perhaps a short case study that may just illustrate that a little bit more. So John was repeatedly asked to go home, and no amount of reassurance helps, which I'm sure some of you will recognise this as quite common. So you actually find out that John built his family home in the country, and he and his wife lived there for over 30 years. The DIY kept him very busy, even in retirement. But now he is bored. He is told he can't go home, and he feels useless. His personhood has shrunk. If we consider that list, what might be his unmet emotional needs? Firstly, I believe it's to feel needed and useful. And this is the good bit. This is the bit where you get to be creative. And you formulate ideas with the help of a lot of input from family, from himself, from life history, from all your research. Some ideas may include find some way he can actually contribute to DIY tasks, even in the simplest of ways. Help in the garden, sanding, a men's shed. And I think an important thing is to actually thank him sincerely for the work he's done. And that's often overlooked. Secondly, I think he needs to have his identity reinforced in a positive way. This may include finding out if he was a builder by trade, and if so, provide him with a safe tool of the trade, like a builder's level or a ruler. Even better still, if you can get his original ones, that would be brilliant. Can he wear a builder's safe tool belt? And could you call him by his tradie name if he had one? I just wish to add in here that sensory needs are a particular interest of mine too. But then while sensory modulation is a whole other webinar, I do take that into account here, and I would think about using smell maybe to calm and reminisce. And you could use fresh wood shavings, or maybe a dirty cloth that he used to varnish or polish the wood. The olfactory senses are our most primitive sense, and they're one of our most powerful to help calm someone. So, and thirdly, I think to be able to express his emotions freely. I think this is often missed out, and some of the early universal emotional needs do not include this. I think it's assumed that a person with dementia cannot feel emotions or forgets anyway. How often is a person told, you can go home tomorrow, when tomorrow never comes? A person with dementia will remember. They maybe not remember what you said, but they will sense that things aren't as they should be, and this will ebb away at their personhood. John will no doubt appreciate being asked about his home, what it looked like. Be genuine. Look at photos. What is it you miss about your home, John? His answer may surprise you and give you a closer look into his world. My second case study is one that's often controversial. I don't know if that's the right word. but I'll call this man Bob. Bob's behaviour of concern is sexualised behaviours towards female residents and staff. Firstly, I always recommend reading and discussing the literature around what causes sexualised behaviours in dementia. There's some very good literature, and I often use the UK dementia sites, and there's really good printouts of those. It actually helps us challenge our beliefs and the language and labels that we may use in that context. And this particular case challenged mine. What I encourage people to do next is use the 3-step plan on behaviours of concern, which will take us back to that slide. This is where we need a lot of detail. Remember, we define the behaviour of concern, we consider the situation, and then we do assess the person. If we looked at Bob, and I'll just pick out a few things, life history and personality traits. What did we know about Bob? This is really important, as Bob also will be trying to make sense of what is happening to him in the here and now by referring to experiences he has had in the past. I think that's important to remember. Bob did not wish to share much of his life history, but what we did find out, he was previously employed as a cleaner and a farm labourer. In the past, he said he liked to help people and keep busy. Bob is separated and estranged from his 2 daughters. We needed to find out what else he did and what was important to him and what his memories were from his childhood. And those things also were looked at and in more detail. We need to remember also that Bob's personality endures through the course of dementia, although some changes are likely. So I think another useful thing to do, and we couldn't do this with Bob because there was no close relative, but I think it's important to find out perhaps how well Bob coped with difficulties in the past. That can give insight into how he may cope now. Was he someone that just blocked it? Did he like to talk about it? Did he do exercise to cope when he was stressed? Whatever, what were his strategies? Again, we need to be creative and think outside the square. The most successful solutions can be the ones we come up with intuitively when we actually know the person. Be prepared for trial and error, definitely. But I think it's really important to remember that we cannot change the person with dementia. We can only change the way we deal with the situation and our own responses. So I've got a brief summary of observations and strategies that were trialled. So what we found out is Bob is more unsettled in the afternoon. He's fully mobile with his frame and he moves quite quickly. Diversional activities help. However, Bob now has a short attention span, and these include doing things like watching movies for a short period. Then we unpicked what are Bob's emotional needs. And we felt that perhaps he needed to give and receive love. Does he need to feel needed and useful? Does he get to express his emotions freely? We wondered whether Bob may be seeking comfort, security, or love. But we wondered how he could do that in a safe way. And we also looked a bit at his sensory needs. From what we knew about Bob's sensory profile, he was quite tactile. He liked to touch, and he possibly liked to be touched too. But we wondered how often Bob actually received positive hugs or touch. We found out that Bob has also been an active man in the past, working on the land, so probably likes movement. Here are a few strategies that were brainstormed and trialled, and of course this list isn't exhaustive. So We gave him the opportunity to feel needed and useful. We gave him jobs to do. We asked him to help others, help in the garden. We gave him the responsibility so his identity was reinforced in a positive way. I don't want to make this sound like it was quite simple. It wasn't. This took a long time. So, as you can imagine. Sensory input through deep pressure, that worked. We placed a heavy blanket on his lap, that calmed him. We tried wrapping a rug or a towel around his shoulders so it felt like he was receiving a hug. Firm handshakes from men worked. He really liked giving handshakes and a pat on the back. Big hugs, hugging a huge stuffed toy. Bob wasn't nonverbal, but he spoke very little. And when he hugged a big soft toy for the first time, he said, "All my emotions." That will always stick with me. Other things we talked about were stroking animals. He may respond to a hand massage. And we took it further about diverting him to have more things to do with his hands. And lastly, it was actually acknowledging how difficult it must be for him to be living with dementia and in care. And we tried to give him the opportunity to share his emotions, which I definitely think the big soft toy did. And we can't forget, we still need to, and person-centred care, part of it still involves other strategies, which you might call behavioural. And one thing that we had to do was maintain consistent, firm boundaries. Don't send mixed signals. Be consistent with everything that the messages you're giving him. And the staff were encouraged to say things rather than smile and walk away if they felt uncomfortable. They needed to say, "No, stop, I don't like that," or "Stop, that's not right." So that was quite hard for some to do, but that was an important part of the whole package. Can I just ask how we're going for time?
You're doing fantastically for time. You've got another 25 minutes up your sleeve yet.
It's all right then.
Keep rolling.
Here is a third example of person-centred care that one of my students shared with me, and it's actually quite a privilege to share it with you. It's short, but I just thought you might like to read it. It's quite interesting. And when you go to the New Zealand Dementia Foundation site, which I have the link at the end, they have really good links to Mate Wariwari, which is the dementia term in Maori. So it's quite, it's very useful. I suggest exploring that some more. And there is an app as well that they have now, which you can have on your computer and on your phone. Just want to perhaps play a few words from one of the greatest fears that I often hear, and I'm sure you would imagine, is people losing who they are. And we often hear, or I often hear, people saying, "Oh, she's not there anymore. She's not the same. There's no point. She doesn't recognise me." But there is an essence and a huge fear of a person with dementia is losing who they are. And I will just share with you this.
Dementia is sometimes portrayed as taking away a person's identity. Judy was asked if she feels this is true for her.
Oh, it doesn't. You are what you are with that. Well, with me, I'll be the same. Exactly the same. Oh, I'm sorry, it's still me. It's still me. I'm just saying.
It's horrible because she was so young, being diagnosed with Alzheimer's, but then, you know, that bits of her do still shine through, and she still is my mum.
Barry is also clear on this point.
Yeah, I'm a man, it's me, and I am me. I'm my wife's husband, I'm my son's dad, and it seems to me that most people, oh, she got dementia. That's sort of like a full stop. End the sentence, end the discussion. She's got dementia, or he's senile.
Supportive relationships with families, friends and professional carers play a key role in helping people with dementia live well.
They're very caring, and I get big hugs from my husband and my children.
It's interesting, isn't it? Because if you're trapped inside and you can't tell people that, I imagine that there'd be moments where your personhood would just be squashed if people didn't know you were in there. Yeah. So I believe if we're truly person-centred, I'll go. Interestingly, I asked my students if they could tell a person 3 things that were most important to them if they were going into care and they had dementia. This is a mixture of students of aged care, residential care workers, some nurses, but mainly caregivers or healthcare assistants and diversional therapists. The first reaction from, and I must confess, most of the nurses was what medications I should take, because they wanted to be safe. And I get that. If you don't have your medication, it could be critical. But so we asked that question at the start, and then when we start talking about person-centred care, and even before that, the majority said things like, what's my favourite food? I'd tell them that I really like my family and I want to visit them to visit whenever they can. I wouldn't, yeah, so I'm sure we would all, if we had to choose 3 things that would be important to us, they would be those things. So it's the emotional and the psychological and the social needs that seem to be paramount when you ask people that question and when we think about it ourselves. So I think if we truly believe that we can be person-centred, or we're really grounded in being person-centred, that we're in quite a privileged position, because it gives us the opportunity to really understand a person and step into their world. The research actually says person-centred care does work. Research conducted trials, qualitative and evaluation evidence shows it makes a difference. And an anecdote and personal experience also tells me it makes a real difference. We need to think of a way we can support a person so their functioning is optimal. And to do this, we constantly need to to be open to learning and trying new ideas, and to be creative. It actually is probably the only opportunity we get to be truly creative. As I said before, no idea is a silly idea. And I think person-centred care allows us to do this. It allows us to stop looking at the condition. And I'm just ending with that slide. Once you've met one person with dementia, you've actually only met one person with dementia. There's certainly no two people are the same, as we know. And I've just included that link because, it should say New Zealand Dementia Foundation, or the last minute slide. That has best practice resources and really good links for GP practices, hospital and residential care. So it's got everything that I've talked about today and snippets and information. So it's sort of a one-stop shop, really. And it's got information on Mati Wari as well, dementia, the dementia associations, Alzheimer's associations, a link to Dementia Alliance International. It's actually got a link for dementia for children and young people as well from the Mental Health Foundation, and how you might support the young people who have got parents with dementia. It's a wonderful site. So that brings me to the end, I think, but I'm be very welcome to hear some questions. People have got any.
Oh, thank you very much, Sharyn. That was wonderful. Already comments coming in from people saying about the awesome insight you were able to give them, particularly with your examples of cases that you've come across in your practice, which was really helpful for people to get that 3D image of what's going on. Another one was saying it was about being beautiful, fantastic presentation, great information. And so someone's asking, how can we refer to you?
Depends what DHB you're in. You can refer to me through the CDHB, but if they're asking that. So will I answer that? I can. So we have one particular referral triage centre, where everything goes. So that's called ACRC. And all the referrals go there in their triage. So I wear two hats. I'm an occupational therapist, 0.3, and a dementia educator, 0.6. So I welcome carers and diversional therapists and some nurses, although we have a nurse that runs that program to do the Walking in Another's Shoes program from the different aged care facilities in Canterbury. But I can't, under that hat, take personal clinical referrals, but I can with my occupational therapy hat, if that makes sense. So I can go into facilities and look at person-centred care if there was a behaviour of concern, and if it meant that a level of care perhaps was in jeopardy, or it meant someone could remain at home for longer so that we could do something to support the carers in the home. So it's,
Lovely, thank you very much. So there's as people are saying they've got some information to take back. Someone said they just started to get soaked into the diversional therapy world, and given them some wonderful pieces of information and knowledge to take back to their job that they're doing. And we've got someone else here saying, hold on, just to wriggle my Kirsta, as a recreational therapist working with nurses, what else can we do or say for our caregivers and nurses to have a bigger insight that emotional needs are extremely important, at times more important than the clinical needs? I have witnessed, and in my professional experience, any recommendations?
I know that is really hard, and I know more so in this fiscal environment that people become task focused, and I imagine that's what you're referring to. Tasks do need to be done, but what happens is sometimes that can be at the expense of someone's perhaps other needs. That is a whole system thing, and unfortunately I can't solve that. It needs to be, to get on board, I believe the manager needs to think in a person-centred way as well. And often people say to me, we just need more staff. And I totally relate to that, because I think you do. I think if there are carers watching this and divisional therapists, you do an amazing job. I get to come and see you, but then leave and go back to an office that's quiet, So it's a very difficult job. And I can only say that if we each do a little bit every day and a little bit more, our culture has changed. If you go back to the way it was, it's come a long way. So, but I know when you're in the middle of it, it doesn't feel like that. So I think even if you can inject some degree of person-centeredness into the way you work and show it to one other staff member, that's a start.
Thank you. And so someone's just saying, I like the expression behaviour of concern rather than challenging behaviour. How can I get into the Walking in Their Shoes programme from a new grad nurse? If you are working in a residential care facility in there's a few of us around New Zealand. So if you're working in Otago in Southland, there's a program run down there, Walking in Another Shoes. So I'm not quite sure how Paula, so I suggest you would ring, it's the DHB run, so you'd ring the DHB. I'm not quite sure how Paula sends that out. There is an educator on the West Coast as well through the DHB running Walking in Other Shoes. And there is one in Nelson and Marlborough, and there is two in the North Island. One, and I don't know the name of the health boards, but one's in Palmerston North and one's in Wanganui. And then there's three of us in Canterbury. I do mainly aged care facilities for healthcare workers and divisional therapists. And then another colleague, Tracy, does healthcare workers in the homes, going to people's homes. And then we have a registered nurse who runs the program. His name is Alan for nurses. So we kind of, depending on where we go, sometimes people cross between the different programs, but that's how we set it up. So the best way to do that is to contact, once again, I'll give you the number actually. It's 337765, and ask to talk to myself, the Walking in Another Shoes coordinator, and I can organise that. I'll talk to you further about it. Do you have a guideline for residents that call out continuously?
I do develop packages. I have got some resources on that. It's finding out why what I mean, there's so many things it could be. I suggest following that 3-step plan, but repetitive actions and words are common. And there is a really good guideline. I feel like turning around and getting it, but I have got a resource, and I think I use the UK Dementia website for that, and it's called Repetitive Behaviours. I think I've got it right here. Oh, Alzheimer's Society. That's a really good place to start. UK. And they have a lot of really good fact sheets with ideas. And it's green like that, so you'll recognise you're on the right website. Yeah, so that's one resource I use, just as a start.
Great, thank you. And someone said, are you able to relay the 6 characteristics of person-centred care, please?
The unmet, the emotional needs. You want to go back to that, or?
They've just said the 6 characteristics of person-centred care. Oh, I wonder if that's the 6 points. That'll be it there, eh? Yeah,
that'll be that there. To
yeah.
Give and receive love, to feel needed and useful, to have the opportunity to care. I wonder whether it's that. It wasn't the VIP, because that wasn't 6.
That should do. And just one last question. Any tips on how to encourage conversation with someone who is speaking less and less?
Depending where you are, we have a speech language therapist. So she will take referrals to go into people's homes and into residential care, and she sometimes will look at communication books if that is what is identified that would work. If you look online at Dementia Canterbury or Alzheimer's New Zealand, they have a communication guides. That's another good place to go. You just Google that. They have all these tips and strategies. So without knowing more in detail about the person, I couldn't say more, but it could be, I don't know if it's physical or whether it's the development of the dementia, or she's word finding difficulties, or so our speech language therapist does look at that sort of thing, so that may be a useful tip to put a referral through.
Thank you. And one last little squeeze-in question, just for good measure. Any recommendation as a team on how to be in sync with our approach? Team means all staff that engages with dementia.
Oh, I know. That's a big one. So I have run, and I do run, and my colleagues, brainstorming sessions. So I kind of try and model it. So I do it in the way that this one here, using that sort of approach. It's just a guide. It doesn't have to be that way, but I actually find that if we go through all of that and brainstorm together, because I don't know if all facilities make time for that. I know one initiative that one of my students another year has implemented. When you're on your feet, and it's hard to remember a lot about a person or the detail, or you might be on your shift, you don't usually see that person, and suddenly you are, and you don't know much about them. So one idea, there was 2 ideas. I really like, I've got to find it. Anyway, it's called the sunflower chart, or the DHB you can Google it, DHB sunflower chart, or COFI. They've changed it to a COFI now. So that is, and I'm sure you've seen it. It's really annoying, I haven't got it here, but it's just an opportunity to write on the leaves a few things about a person. So at least that's a start. So then you can walk into a room and you can see a little bit about the person. But another thing, I guess, to get people on board is case studies. presenting them. Or if that's a bit too hard, even sharing a little bit of life history about a person in a team meeting at handover. So you just choose one person and you give people a bit of that rich information. That might be another way of just starting to get people on board.
That sounds lovely, Sharyn. Sounds like a nice idea. And someone else has said here, maybe inviting Dementia New Zealand into facilities during training could be another thing, maybe useful.
Yeah, definitely.
It's just getting your head into starting to think in that way rather than just falling back on the labels. And
and I know we get busy. Get busy, and it's hard to change a culture when you're. It's hard. Work cultures are strong.
There's someone saying about personal music downloaded onto wireless headphones. Made some positive changes. Lots of residents enjoy the music on the headphones. Residents who spoke very little singing their hearts out.
That's a really good idea for that person that said, that their resident wasn't talking. And actually, I didn't mention that. That was something we actually used with Bob. We tried with Bob as a way of just calming him, listening to some personalised music on our headphones.
Lovely. Thank you very much. It's been a fantastic presentation. There's been heaps of messages of thanks and how inspirational you've been, and the information that people are taking back to their own places of work going forward. And it's nice to always have those few resources as well that you can go to, knowing that you can get that extra information specific to your situation as you move forward. So thank you very, very much for your time this evening. It's hugely appreciated across New Zealand.